I see you.
Hello.
How's it going?
Good. How are you?
We just joined the live and my puppy just knocked over water everywhere. So we're,
I
we're
love
fine.
it. How old is your puppy?
She's 3 months, little
Oh,
baby.
I love it.
Well,
Love it.
yeah, we had to switch over to TikTok, guys, because Instagram is being weird. But thanks everybody for being here on the fly.
Yeah.
So why don't you introduce yourself?
Yeah. So, hi everyone. I'm the pain relief doc. I'm a double board certified anesthesiologist and pain specialist. And yeah, I'm just very excited to be here and to chat tonight and to meet everyone.
Tell us a little bit about you, like your practice and what you do. I'm really excited to talk to you about just like what you do and how we collaborate
Yeah.
because I think most people in medicine know that we work together a lot, pain relief or pain and neuro and spine folks. So
Yeah.
it's really cool to see like all these newer technologies that we can help people
Yeah.
with their pain. What is your like favorite procedure that you do?
So I have to say, I really like basivertebral nerve ablation. Is that something you're familiar with?
Actually, like, yeah, my pain colleague in my practice does it.
Yeah.
And we are actually just talking about this the other day. So
love
tell
it.
people what that means.
Yeah. So the basivertebral nerve is a nerve that basically provides innervation to a certain part. Oh my gosh, where's my spine model? To a certain part of your
Yeah, you
vertebral
need
body.
it.
And so basically, this is kind of the front part. It's called the end plates. And so a lot of patients who have that type of pain, it's called anterior column pain. So a lot of times they'll have pain with bending over and a couple of different things that it's really important to get on history as well as physical exam to rule out other causes of back pain. And essentially what we do during that procedure is we go into the vertebral body, kind of like a kyphoplasty, and we access the vertebral body and then we deploy some probes that essentially allow us to ablate the basivertebral nerve. And so the nice thing about that procedure, which is a little different from other ablations that we do, because we do also do ablations of, the medial branch nerves, but this is kind of a one and done. And so we're able to do that at a particular level for a patient, and then, they don't have to kind of do it again. Thank you. So this is I love my spine model. I'm always like in clinic, I'll like pull up pictures and use the spine model. So this is the vertebral body, and so the basivertebral nerve kind of courses this way, and so we go in here. It's a pedicular approach. Some people do like an extra pedicular approach as well, and then we can go ahead and ablate the basivertebral nerve. And so the end plate is kind of this part of the spine. And so we'll look for certain changes on MRI. So motive changes are something that we look for on MRI. And there are some other things as well. So it's great. It's a really great procedure that can help a lot of people.
And that's the Intracept procedure, correct?
Yeah, Intracept.
Yeah,
And
the
then
one
there
I've seen.
is another company that has come out with kind of their own tools for it as well. So now it can kind of be referred to a little bit more generally as a basivertebral nerve ablation. But yeah, Intracept procedure.
And like, for me, like, I think it's really cool because, it's hard to know patients that are like, we do a lot of disc replacement for similar problems or motive changes and impulse. And I think that procedure as well, but it works so well. It's one of my favorite procedures we do. But if an Intracept procedure can help patients, before they get to that point of needing hardware put in their spine, I think it's worth a shot, even though, it may not be successful in everybody, but back surgery is not successful in everybody either.
Exactly.
So
Exactly. And it's, minimally invasive.
tell us a little bit about, I think I'd love to learn more about like Botox for migraines. That's I think a question a lot of people have on social media, and like, how do you know, like, who do you recommend this to? What's your approach?
Yeah. So Botox for migraine, there are a couple of different protocols. So one protocol is called the preempt protocol. And so there's 30 specific sites that we inject with Botox, very specific dosing that we use for it as well. And then there's another protocol called follow the pain protocol that I use for my TMJ patients, because then I'm able to capture other musculature for them. But essentially, patients have to have failed for, other kind of treatments. for this to be covered by their insurance. And so, I've had the patients who have tried a number of different things. And even as far as I'm concerned, if I can get someone to, someone to have it covered by insurance, I will. So I'll look for whatever 4 things it is that they've tried, whatever 4 medications it is that they've tried. And then typically we'll submit to insurance if that's something that they're interested in pursuing. So I think it's a great option, for migraine patients. It's something that I've seen help a lot of people. And so definitely something, to discuss with an interventional pain physician who does that, or headache specialist, neurology trained also typically offer that procedure.
Yeah, my pain colleague does them too. And so sometimes we have a little extra Botox on clinic days. So
yes. 155 units is what the protocol calls for. And it's usually in intervals of 100. So we'll always have 200 units, of Botox, and then 45 to kind of waste after the procedure.
Okay. All right. That makes sense why we always have 50 units.
Yes, that's why you always have some.
I gotcha. Okay. Tell us what was it like? What percentage of interventional pain management physicians are women?
I think the number, because I actually was involved in a paper on this, I think it was 3% at the time. And that was in,
holy cow.
Gosh, I think it was 2019. Yeah, we're not well represented at all. But I think because we're in such a unique bubble, it's particularly you, right? Because you have such close proximity to a lot of these women in interventional pain. But we're definitely severely underrepresented for sure. So it was about 3% at the time.
Are you anesthesia trained or okay? And the percentage of, I think, what is the percentage breakdown of pain management for anesthesia trained and PM&R and others? And what are your thoughts on if someone says, hey, I want to be a pain doc, what pathway?
Yeah. So for your first question, the breakdown kind of depends generationally. So there's actually, and this is something that's being talked about a lot in the pain education space, is actually the change that's happening because of the current landscape of anesthesia. A lot of people are electing to actually not do fellowships. So just across the board. So critical care fellowships, a number of different fellowships, anesthesia residents are electing not to pursue them. And so we've seen a massive shift in kind of what the, residencies that people are applying into pain are coming into. So there's a much larger group of physiatry residents, PM&R residents applying into pain. And then we're starting to see more emergency medicine applying into pain as well. Neurology. Yeah. And then neurology is a specialty that's not as recent, they have been kind of applying, definitely a minority of them. And then some psychiatry as well. But that's actually a really big conversation in the graduate medical education space for pain, because it really changes the approach, because obviously everyone from different residency programs is going to come with a different skill set, right, to the fellowship training program, which is 1 year. And so there definitely has to be kind of a recalibration of what are the skills that people are coming into it with, and how can we get them ready for practice in 365 days. So the second part of your question, I actually was part of a multidisciplinary pain fellowship, which I absolutely loved. So we rotated through psychiatry, we rotated with neurology, we rotated with PM&R in the sports clinic. And so it really allowed me to appreciate the multidisciplinary, aspect of things. And I think that everyone brings a very unique perspective to the practice of pain. And so I have some buddies who are PM&R, and, I'll reach out to them for some very specific things. And then they'll reach out to me for, a lot of the pharmacology things, or questions about ketamine and things like that. And, regional blocks and things of that nature, just because that's kind of something I'm very familiar with my anesthesiology training. So right. I think we all bring something very unique, and I'm definitely not the one to feel like one's better than the other and things like that. I think we all bring something very unique to the field.
Right. And each training can mean different, knowledge base, and each program is different. I mean, honestly, like I was talking with Dr. Gilmer about that earlier about ortho spine versus neurospine, and it can be just so different. And, so many of these like fellowships and super subspecialty, like what we do, what you do is unique. Someone had a really good question. Jenna asked, like, what's the role of APPs in pain management? And do you see a good number of APPs shifting towards pain medicine?
Yeah, that's a great question. So definitely a big role, so in order for us to improve access to care, we can't have kind of a physician only care team. I really don't think that works long term, certainly not if you're trying to scale and improve access to for patients. And actually, as a fellow, I was involved in training a nurse practitioner who, came on. And so they definitely come again with a set of skills, and there's a lot that you can teach them where they're able to, for example, there's some practice models where the physician might see the patient the first time and then kind of outline the treatment plan. And if it's not procedural or the treatment plan is something very kind of straightforward and outlined, like, okay, we're going to start gabapentin and this is the titration plan and things like that. That's certainly something that an APP can help manage, so that we can improve the access for patients to specialized care. So that's what I would say about that first part of the question. And whether or not there are more APPs going into pain, I've seen that. I've definitely seen some people interested in transitioning from the bedside or, from like an inpatient or from like a family practice to pain. But I think if we're to say like, greater numbers, I feel like more are probably transitioning to aesthetics personally is probably what I think. Yeah. But yeah, there's definitely an interest in the pain space.
Yeah, I think APPs are like, I know there's like this weird dynamic in the physician community, which is unfortunate because really there's like growing less and less number of physicians and burnout and all these things. And like, APPs are improving our patients' access to care, but also like to your point, like, there are great, PAs and Ps that can provide this care to patients that we do too, but allows us to still increase patient exposure to procedures. Right. So like if I have PAs that can work the patients up, know what I do, work with me, make the diagnosis, I'm able to perform more surgeries, which is ultimately greater for the community. And same with you, like you can do more procedures. And, I think it's just like such a great, like one of my passions is really just kind of helping, kind of lift up this community and just trying to explain the roles of how they can help both the patients into the medical community. Because I think it's unfortunate when we think of like, practice scope creep and all this stuff. But I don't know, at least in my specialty, my PAs are invaluable to me being able to like just serve more people. So
yeah, and I think it's about operating at the top of everyone's license, right? Just like I think that NPs shouldn't be relegated to something that doesn't require their training. You know what I mean? So I think it goes for everyone on the team and really maximizing the expertise of each person and the role that each person plays. Just like how a front desk, like clerical person, if they can operate at the top of their training, they can make a world of difference for patient access. And so I think that we kind of really need to reframe that and see that each role is valuable. And it's about everyone being able to be in an environment that allows them to, do the best that they can for as many people as possible.
Yeah, I agree. Doug asked, liked you talking about ketamine, and he wanted to know like what your thoughts are on the use of ketamine in pain management.
Yeah, so I trained under the author of the ketamine guidelines. So it was something that was definitely a big part of our institution, definitely a big part of, our training. We used it in the anesthesia world. We used it on the inpatient side, definitely during surgery and as well as for post-operative pain on the inpatient acute pain service. And then we also used it on the chronic pain service. And then we also had an outpatient ketamine clinic for chronic pain patients. So I think that forget, IV ketamine is a very, very important modality for patients, particularly in a number of treatment-resistant conditions. And, you know, the science and the evidence is there to support it as long as it's done safely and in a safe setting, you know, by people who are appropriately trained to monitor and to treat the complications that can occur. I think it's a really great option for patients. I think it's unfortunate that it's still not really covered by a lot of, you know, insurances for other different conditions. So it's a massive out-of-pocket expense. But I have seen it do a world of difference for people.
Yeah, it's really interesting. I mean, like this just whole dynamic of healthcare right now. And I saw a good video by, I think it was Dr. Masterson. He posted something. He's like, just talking about insurance stuff, and I'll digression a little bit, but he said like, if they don't want to, like, if they don't trust us to be physicians, then why did they give us licenses? If they want to kind of like intervene on what's covered and not covered. And I was like, period. Like that is so fucking
I love his insurance content. It's great.
It's so good. It's so good. There was a question about Journavx, and someone started for arachnoiditis. I recently learned about Journavx. It's a new like pain med. For those who don't know, it has different mechanism of action than most pain meds. I've started like prescribing it like crazy, and I'm curious to know what your thoughts are.
Tell me, I'll get into it, but tell me what your experience has been with your patients, please.
So
I'd like to sip my tea.
I feel like I'm stepping into something I don't want to.
No, please.
So you know, so I saw some data supporting it, like in the post-op patients, like, you know, right after surgery and how it can reduce narcotics.
Sure.
But I've started like really discussing it with patients with acute pain. I mean, chronic pain's a whole nother story.
Yeah.
And just kind of like feeling out like what my experience is. And I'll say that in like purely nerve pain, and patients I might, you know, prescribe like a narcotic for, otherwise, like I feel like it really helps their pain. I'll give an example. This is maybe not the best example, but like my medical assistant, he, a dog crate like smashed his finger, broke it 2 places, had to have a pen last week. He took Percocet, didn't touch his pain.
Yeah.
He took Journavx, and he's like, I don't know what it is.
Awesome.
It like helped his pain. So he takes Journavx, only no narcotics. So, and that's, you know, I won't say every patient's like that, but I'm curious to know your thoughts and what the data shows that you read to know if I'm doing the right thing.
You're definitely doing the right thing. So a lot of the data was in a different patient population. So it was plastics patients as well as podiatry patients. And then essentially it was determined to be not inferior to, I believe it was ibuprofen and Tylenol. And so I think my
That's right.
So my kind of like thing with it is, and especially because the context that it really came under for me wasn't so much acute pain, you know, post-surgically or, you know, just acute pain. It was really my chronic pain patients who, whether they had like sensitivities to gabapentin or, you know, different gabapentinoids, and we had just tried so many different things. And my issue really is that it just doesn't seem to really be supported. I mean, I actually had meetings with them before it came to market, and I had, you know, I was like, it'd be really helpful if we can really see some data on these patient populations, because the chronic neuropathic pain patients need solutions. Like, we do not have enough tools in our toolboxes to help these patients. And if we can do something for them by, you know, kind of taking advantage of the sodium channel, we need something, you know, and that's not really, it's not really proving to be helpful there. And so the other barrier has been cost. Maybe it's improved for some payers now, but the cost is really astronomical. And so that's another barrier for someone to be on it chronically. For an acute period, you know, like a 2-week period or something, that's one thing. But to be on it chronically is another. And then thirdly, I will say the patients who felt that it helped them, it wasn't like a miracle drug like your MA, which I'm so glad that he or she had that response. But it's really kind of like, okay, it turns the noise down a little bit, you know? So it's like, okay, if it turns it down a little bit and it's that expensive, does it make sense in your treatment regimen? But I will tell you, my approach to patient care is always, I'm here to help you and to help you get to what your goals are. And so if this is something that you're interested in pursuing, I'll give my insight, and if they want it, I'll prescribe it, and then we'll just kind of go from there. So I'm never one to kind of tell people it's not going to work or something like that, because you just don't know. People respond to things differently. And honestly, I think the same goes for, I know some people in the surgical realm, they kind of feel like interventional pain doesn't really do anything. But I really feel like, if a patient wants an option and is interested in pursuing one, I'm going to educate them to empower them to make the best decision for themselves. But, ultimately people just respond to things differently. So.
Yeah, no, I agree with that. Yeah, it's interesting. I mean, just pain patients in general, like I know what I experience in my practice and what, comes in your clinic every day. The most frustrating parts are the patients that have pain that we just really can't get a grasp on, in those neuropathic pain patients, arachnoiditis patients, like neuropathic, neuropathy, or whatever the case may be. I think those are I agree, the most challenging. And we have like spinal cord stimulation, peripheral nerve stimulation, all those things. But like when those fail, then what? And it's just like, I don't know.
Yeah, it's really tough. It's really tough. I mean, there's like, I don't know if you're familiar with Qutenza, the high dose capsaicin patches for like painful diabetic neuropathy. So there have been some times where we've explored the possibility of like doing this off label, which is like, the insurance may or may not cover it because it's only cleared for painful diabetic neuropathy and post-herpetic neuralgia. But that's something that I will have a conversation with patients about if they have one of those two, and they come to me with like really severe foot pain. It's like, okay, yes, there's the radiculitis. Yes, there are these other things. But if we can remove some of these signals, and get some of this stuff to quiet down a little bit, then that's typically something that I'll talk to them about, even if they have other overlapping syndromes on top of it.
Yeah. Yeah, I agree. All right. I do have a hot take question. So, what are your thoughts? Like, I see this a lot, like patients that have spine surgery and like are immediately like turned over to a pain physician to manage postoperative pain or postoperative complications. I've seen that happen before. Like, what are your thoughts on that? How do you handle those situations? And what, like, could we do better to help with that? Because I think I don't know. Do you find that to be a challenge where you don't have that problem?
Yeah, so that really will depend on the clinical setting of different, everyone. So in the practice settings that I've been in, that's not been my experience. Good. Because, so I've not really kind of gotten that. So typically, the surgeons will keep that aspect of care for 3 months.
Yeah.
At one of my facilities, there was actually a program that once the patient kind of exceeded that 3 months, it was actually like a program that would try to help the patients wean them off of it. But it was kind of an ancillary service outside of the chronic interventional pain clinic, because again, it becomes a question of access to care, right? And so if there's another service that can take care of those things, but in private practice, then that's not really something that you're going to have access to. That was an academic setting. So it's not really something that I have had to deal with. I would say that,
that's my experience. And that's typically what I do is I, care for my patients for 3 months. That's like our clinic rule. Yeah. But, I've had other physicians, other surgeons, like just punt them over. And I feel like it puts the patient and the surgeon for that matter, but the pain doctor really awkward situation because they're managing postoperative pain. If there's complication, like, I don't know, it's just maybe that's just my experience, but I was just curious, like, how you handle that. But
yeah, that's tough. I will say, like, if someone comes to me, I've had like a couple of patients kind of before the 3 month mark. The general advice I would give, even, for you, if you're kind of dealing with this, is just to maximize your multimodal agents. Yeah. So, you really want to make sure that you have a nice muscle relaxant on board. Flexural isn't really my muscle relaxant of choice, so you want to make sure you have like a good muscle relaxant on board. If you're fine with them being on NSAIDs, and you would consider, a COX-2, instead of like an ibuprofen. Make sure that someone's on Tylenol around the clock. As many topicals as possible. I know that some people scowl at lidocaine patches, but sometimes they do help. And then the other thing that I see a lot of, I think it's just that's not maybe something that you guys are exposed to as much, is the use of actually SNRIs or TCAs. So TCAs, I actually reach for those before I reach for SNRIs now, because they've been shown in comparative studies to actually be superior to SNRIs when it comes to, neuropathic pain and even some musculoskeletal pain. And so that tends to be something I'll reach for if I do get a patient who has not quite met that 3-month mark, but they're having a lot of challenges. I'll make sure that I add something that can modulate at that level. And that can be extremely helpful. So that would be something to consider and think about.
Yeah. So the people that like don't understand what she's talking about, TCAs or tricyclic antidepressants, so like amitriptyline or something like that.
Nortriptyline has a better side effect profile. Mm-hmm.
Yeah, so I had fun story about that. I had like in residency, I had a cholecystectomy, gallbladder removal for like acute cholecystitis. But after the procedure, I was having this like pain like in my abdomen, and like no one could figure it out. And I'm like, I am not making this up. Like I almost felt like I was gaslit. And I'm like, am I crazy? I know I'm stressed, but anyway, one doctor like put me on nortriptyline.
Yep.
And I mean, it was like poof, gone. Yep. And I'm like, this is bizarre.
I love nortriptyline. Nortriptyline's so good. And a lot of the GI folks, they'll use that, for people who kind of treat like chronic like abdominal pain, you know what I mean? Like from the GI kind of functional side. But yeah, nortriptyline. So just think about it, I start at 10, I go up by 10 milligram intervals to 50. There's certain things you need to watch for, but it can really be a game changer.
Yeah, I stayed on it for about a year, and then I weaned myself off a little bit, came back, so went back on it, and then weaned off like probably a year and a half later, and it's fine. I don't know what it was, but I was like, all right, I'm a believer now.
It's really good.
Yeah. So let's see. I think there was one other person that asked the question a few times. So we'll end with that. Someone was asking about Suboxone and kind of like if someone is kind of still not getting relief on Suboxone. I don't know if you can touch on that at all.
Yeah. So Suboxone really would be thought of as not necessarily like a pain medication, but more so, an opioid use kind of maintenance medication. Buprenorphine is the opioid component of that. And that's certainly something that can be titrated if someone's not getting relief. So to that question, my question would just be to the person, what is being treated? Yeah. Because depending on what's being treated, if they're on it purely for pain, without a history of substance use disorder, then it may be time to kind of engage with the prescriber regarding alternative options or clarify why that was the option. But if there is a history of opioid use disorder, then there's gonna kind of have to be a little bit more work done. Yeah. And certainly addiction specialists are really, really well suited to help in that regard. Absolutely.
Yeah. Well, she disappeared when you asked the question. So I don't know where she went. She has it like 100 times and then faded away, of course. So anyway, well, I like just to kind of finalize, I want you guys to know what an amazing creator the Pain Relief Doc is. Her stuff is so good. And I just wanted you to kind of like update everybody on what you're doing. And
Yeah, thank you so much. I really appreciate that. I have a lot of fun, and I really want people to feel empowered to kind of make the best decisions for themselves. So we're kind of taking that a step further, and my school community is live. So I'm excited to dive deeper into, just helping people with understanding their pain and developing strategies to move better and feel better. So you can join us on the school community. I will update my TikTok bio, if it lets me. I have a hard time with links on TikTok. On Instagram.
Find you on Instagram because
You can find me on Instagram and at the Pain Relief Doc, and then there will be a link to join the Pain Relief School community.
So school community, just for those that don't know, is basically an online community where educational content. What stuff do you share on your school community?
So it's going to be educational content. We're starting with people can submit questions, and then we're going to be doing some lives, and then I'll be sharing, some insights every week on there as well. And then there's definitely more to come. There'll be some different kind of educational content coming available to you. Yes,
so good stuff. So y'all can go to her Instagram, the Pain Relief Doc, right?
Yes.
And yeah, thanks guys for joining, and hope you guys learned some stuff. I learned a few things. My dogs are barking on cue, so
love it. Thanks for having me.
Yeah, have a good night, and thanks for
joining.
All right.
Thanks.